set up on Facebook, so give us a
Yeah.
second here. Are we ready?
We're ready.
Okay, good morning and welcome to the November 22 monthly meeting of the Louisville Metro Board of Health. This meeting is called to order. The meeting is being streamed live on Facebook. We take a moment to wish a continued full and speedy recovery to Paul Pelosi, and in so doing, we strive to do all in our power to encourage and engage respectful dialogue, especially when we have conflicting public policy, political, religious, or other benefits. We should emphasize solutions that bring us together, not tear us apart. One thing is certain, though, public safety for all continues to be in the forefront of public health and requires collaborative community partnerships to elevate Louisville as an example for the country. Now for the approval of the October meeting minutes, which were previously distributed. Are there any edits to those minutes? And if none, the chair will entertain a motion to approve. Ms. Handmaker.
Sorry, I was on mute.
Okay.
I move that the minutes be approved.
Okay, is there a second?
Second.
Thank you. All in favor?
Aye.
Opposed? Abstentions? Motion carries. Now give me one moment here, and I am looking for, so Rebecca, we will probably go early with your presentation. I'm just looking for our speaker because we will run a little early. Moving on with today's agenda, per my pre-board note, as we transition from this stage of the pandemic, we should reflect on how the public, private, academic, social service, and faith-based sectors fared, and whether insights from during the pandemic, how they fared during the pandemic, and whether from those insights have we indeed let them inform system change, environmental system change, and public health reforms. It will be interesting to follow the state of Florida's preparedness, recovery, regeneration, actions, and outcomes as a result of Hurricane Ian, given the fact that many other communities at some point will likely experience their own environmental disruptor. As I mentioned at our last meeting, our city must ensure that advanced public health surveillance mechanisms are in place to give us early warning to mobilize. That's the area that interested me most this past month, as Dr. Howard and I met with relevant public, private, and academic leaders to discuss designing a digitally driven surveillance system using signals from our air, water, soil, etc. This approach ensures that we have accurate and ongoing real-time data from which we can more effectively manage equitable community health outcomes, a giant leap forward from our COVID experience. Given there was no data available for months at the outset of COVID, we later depended on what are called lagging indicators to inform and develop our community's response and recovery efforts. Think about hospitalizations, deaths by zip code, etc. We could do little to stop the spread due to lack of real-time accurate data. We needed leading indicators that give us time to mobilize resources effectively and to target those resources equitably. As the pandemic continued through the work of the University of Louisville Medical School researchers led by Dr. Ted Smith, Executive Director of the Environment Institute, The Institute enriched its pathogenic testing of wastewater, the result of which was and is we are able to target those geographic areas most impacted in order to abate the spread. Said differently, we had a 2-week lead time with this type testing. A few weeks ago, I asked Dr. Howard whether this continued testing would surface other outliers in our water. Think polio, monkeypox, and today's new BA, and I've lost the count, 5, whatever the scientific names are, variants. At the time, only COVID was being identified. After meeting with Ted Smith, there is now work underway with the University of Louisville Medical School researchers to develop what is called a pan-virum view of what we learned from ongoing wastewater testing for a host of pathogens which are continually tracked. The health department is funding this initiative. We will keep you updated on progress. And in fact, next week I'll be touring the lab where this is happening, and we'll report back on learnings from that journey. This is most definitely next-gen public health. And let me look at my screen. Do we have Dr. DeJarnett on yet? Okay, well then, let's move on to, I'm going to skip to the, hang on just a second. Alrighty. Let me go first with the chair's report with everyone's consideration, and we'll deal with about 4 updates here. First, from our, let me see. Thank you. Let's see. I see Megan Metcalf. Great. Welcome. First, from our previous meeting relating to the strengthening of the city's rental property code by adding increased enforcement to ensure rental properties and their individual units are lead-free. You may recall that the issue was tabled by Metro Council until after the election. I believe a new ordinance was set to be introduced this week by Councilwoman Armstrong Fowler and Councilwoman Fowler this week. A copy was included in your materials. Rebecca Hollenbach and Connie Mendel's team have been working with the council and Councilwoman Armstrong on that ordinance. Rebecca, the floor is yours for a moment to discuss the overarching details. And at the same time, we're honored to have Councilwoman Armstrong's legislative aide, Megan Metcalf, join as well to answer any questions that you guys might have related to this. Let's see. And I see that Dr. DeJarnett has joined. So pause 1 second. Let me check to make sure she's live. Okay. We started a little bit before you dialed in. And so let me rearrange so that we can introduce you properly. And Megan and Rebecca, hold your fire, so to speak. And we'll go to Dr. DeJarnett for our perspectives this morning.
Thank you so much for having me.
Okay, let me give a little intro to this section. We, previous to your joining us, had talked about next generation public health, and it's in that scope that we welcome you to the November meeting of the Board of Health. Dr. Natasha DeJarnett, PhD, MPH, her area of concentration is environmental health. Her experience spans epidemiology and clinical research based on an interdisciplinary approach toward assessing environmental health challenges. Her perspectives are intended to stimulate a discussion on any future public health policy needed to advance equitable, improved health and environmental outcomes. You will receive a copy of her presentation in the post-meeting update that the chair sends. Dr. DeJarnett, we're honored to have you join us. The floor is yours, and we have your presentation on the screen. So give us a second to get it up there. Can everybody see that on their screen? Thank you.
See it, Heidi.
Proceed, Dr. DeJarnett. Welcome.
Oh, thank you so much. Thank you for having me. Thank you, Heidi, for the kind invitation and the great opportunity to be here. So I'm from University of Louisville's Christina Lee Brown Environment Institute, and our center fills a void through our framework to understand the environment as a whole through our interactions with the natural, social, and personal domains. And that's what we describe as the environment. So we're complete with 7 collaborative research centers and partner among and across disciplines, as well as with the community, to understand the environmental burdens of disease and identify interventions to improve health and quality of life. So today I'll share about the ways that air quality and extreme heat in the context of climate change impact health, but also some solutions. Next slide, please. So climate change is the greatest threat to human health. According to the Lancet, the World Health Organization, the American Public Health Association, leadership at the National Environmental Health Association, and countless other health societies, these groups have declared that climate change is the greatest threat to human health. And to bring further evidence to this, just last fall, over 200 biomedical journals came together to affirm the need for climate action to protect health. So the health threats of climate change are vast. But one thing I want to make sure is clear is that while we're all at risk to the health threats of climate change, some groups are more susceptible to these health threats, and climate change can actually be a threat multiplier for them, exacerbating some of the inequities that these groups already experience. So consider children. Children, according to the World Health Organization, 88% of the global burden of climate change falls on children younger than 5 years old. So this is certainly a generational injustice, and they're more at risk for a number of reasons, including that their organ systems are still developing. Older adults, they're more likely to have chronic diseases that render them more susceptible to the health threats of climate change. Communities of low wealth may lack the resources to support infrastructure updates or to recover quickly following an extreme weather event. And these areas may also have limited access to needed healthcare services. Communities of color are more likely to live on the fence lines of the industrial polluters. And the single strongest predictor of where hazardous polluters are located is race. It's not income or other factors. People of color make up a majority of those that live within 3 kilometers of a hazardous waste facility. Indigenous communities have close cultural and religious ties to the land, and climate change is affecting their ability to hunt and gather food and pass along these rich religious and cultural traditions. When there's the threat of extreme weather, people have better health outcomes, especially mental health outcomes, the sooner and further that they can evacuate to safety. However, people that are living with a disability may have challenges in evacuating safely if they're experiencing mobility challenges. Undocumented residents may not feel comfortable evacuating to a shelter following an extreme weather event for fear of deportation. And similarly, members of the LGBTQ+ community may not feel as comfortable evacuating to shelters for fear of discrimination or worse. So I share these unique burdens that are faced by these populations because we cannot truly address climate change if our most disproportionately burdened don't benefit from action. Therefore, we can't meaningfully address climate change if justice is not at the center. Next slide, please. So climate change not only threatens our physical health, but it affects our mental health as well. So exposure to extreme weather and floods can increase our risk of stress, anxiety, post-traumatic stress disorder, and depression. Extreme heat or extreme weather can increase risk of depression, violence, suicide, and suicidal ideation. And extreme heat can even render inactive some psychotropic medications. So rural communities, Indigenous communities, and pregnant people can all bear a heavier mental burden to the threats of climate change. Next slide, please. So we all deserve clean air to breathe, but climate change is decreasing the quality of the air that we breathe. It's increasing carbon dioxide levels in the atmosphere, trapping heat and pollutants below, much like a blanket traps heat. So the extra pollution decreases our air quality, but this extra trapped heat further reduces our air quality. And then climate change promotes these drought conditions, which create environments that are conducive to wildfires. And the smoke from wildfires reduces our air quality. So wildfires emit particulate matter. And while we may not face wildfires directly often here in Kentucky, the smoke from the wildfires in California actually reached us here in Kentucky and all the way to New York last year. For about a 1.5 week period, we had decreased air quality here because of the wildfires that were taking place in California. Further, the warmer temperatures are resulting in a longer pollen season, and research suggests that having more carbon dioxide in the atmosphere is increasing the intensity of the pollen. So we have a longer and more intense pollen season, and this is bad news for allergy sufferers. But there's another allergen that we're also exposed to, and that's mold, and that can result after flooding in our homes, schools, or other places. So in summary, poor air quality is associated with increased risk of heart and lung disease. With this intensifying pollen season, we have the increased likelihood of allergy symptoms. And all of this is more than just a nuisance. Both allergies and asthma increase the likelihood of school and workplace absences and decrease productivity. So there's a new paper that was published in the New England Journal of Medicine by Dr. Susan Annenberg and colleagues, and they present findings linking fossil fuel related air pollution to every major organ system in our body. So children, communities of color, low wealth communities, and those that live on the fence lines of industrial polluters certainly bear a higher burden of poor air quality. Next slide. So what are we learning here in Louisville? Well, there are several factors that can be protective against air pollution and heat, including green infrastructure. So these maps are of Jefferson County, and in the Louisville Healthy Heart Study, which was a study that examined the environmental determinants of cardiovascular disease, we looked at greenness across Jefferson County. And so this light green shading indicates areas of low greenness in our community. You'll note that the western part of Jefferson County has lower greenness than the eastern portions of our county. And as you are well aware, there is up to a 12-year difference in life expectancy when comparing West to East Louisville. Please animate. Thank you. So going further in this particular study, we examined the links between greenness and exposure to volatile organic compounds. And volatile organic compounds are a group of chemicals that can evaporate readily at room temperature. So they're released in industrial emissions, they're in vehicle exhaust, but they're also in man-made sources like paints, like cleaners and disinfectants, and even cigarette smoke. And these chemicals are important to discuss in the context of climate change because under the right conditions, VOCs are actually a precursor to ozone formation, which is a climate harming pollutant. So you'll note that several of these metabolites of these volatile organic compounds are detected at higher rates in people that live in areas with lower greenness. And next animation, please. So further, to connect this more directly to health, our research from the Louisville Healthy Heart Study found that several volatile organic compound metabolites were associated with increased cardiovascular disease risk. In particular, we found that in acrolein and benzene, levels of acrolein and benzene were higher in people that had higher cardiovascular disease risk, and that was whether or not they were cigarette smokers. Next slide, please. Now, changing gears towards extreme heat. Climate change has increased the severity, the frequency, and the duration of extreme heat events. And this is concerning because heat is the top cause of natural weather-related death in our nation. Extreme heat increases our risk of heat-related illness, including heat stroke, which can be deadly if not addressed quickly. It raises our risk of respiratory complications. And further, there are mental health impacts, including increased violence and aggression under extreme heat conditions. In addition, it exacerbates the risk of cardiovascular mortality. So populations that are most susceptible include older adults who are more likely to have chronic disease, but also experience social isolation, so may not be as aware of extreme heat events. children who spend more time outdoors. They don't really have the capacity to know when they've overdone it, need to come in, need to take a cool glass of water and cool off. Communities of color and impoverished communities are more likely to live in urban heat islands, and the EPA has reported that urban heat islands can be as much as 20 degrees hotter at night compared to surrounding areas. But also, people that work outdoors in construction or agriculture, they may be more likely to be exposed to extreme heat as well. Next slide, please. So putting a spotlight back on Louisville, Louisville has one of the fastest growing urban heat island effects in the nation. According to Climate Central, we have the 5th most intense urban heat island, we have the 6th most intense overnight urban heat island, and the most days above 90 degrees compared to our surrounding areas, and the 4th fastest growing urban heat islands. So when we look at the distribution of heat mortality in this study by Dr. Stone and others, you see that it's greatest among the west and southern portions of our county. And then in the map on the right, some neighborhoods have a higher density living along with lower wealth. They have higher heat mortality compared to those that are less dense with higher wealth. And so I've put actually a box around our Green Heart neighborhoods. They're outlined there in black, which I'll come back to Green Heart in just a moment. But if you could animate one time, please. I share this because you can see that heat mortality overlaps almost directly with heart disease death rates in our community as well. Next slide, please. So wrapping things up, I want to share that there's much that's being done around climate and health adaptation, adapting to protect health from the current climate exposures we're experiencing. So there's much that's taking place across our communities, including testing air quality, disseminating, and ensuring that that dissemination is far and wide of heat alerts or air quality alerts, and enforcing regulations. Establishing cooling centers, but also making sure that people can actually access those cooling centers when they need them and know that they're available to them. But another key adaptation feature includes green infrastructure. So one of our answers to cardiovascular disease prevention in the face of poor air quality and extreme heat is the Green Heart Project. And this project is supported by the National Institute of Environmental Health Sciences, along with several other partners in the community. And it's a study that is a controlled trial where greenness, or trees and shrubs, are the intervention. So we're planting trees for healthier air, and we're examining health indicators and air quality levels before and after tree planting. So Green Heart provides an opportunity to establish roots as a healthier and greener neighborhood. So tree planting started in October of 2021, and it ended in July of this year, and over 8,000 trees have been planted. And there are a lot of factors that have contributed to the success of this project thus far, including effective community engagement, that it was community driven for the tree intervention, that we have strong partnerships, and also that we work to address the barriers of trees, or barriers that trees may present among residents. So with that, I'm happy to take any questions. You can go to the next slide, which includes my contact information. And I thank you so much for your time this morning.
That is informative, insightful, and is clearly a riveting call to action. There's no question about that. And let me ask you an opening question and then turn it to the board, and we'll take board members first in questions. So looking at other cities in your work, because you are clearly nationally recognized in this area, are there other cities that are best practice examples? And are there any specific public health policies that would be that could serve as a catalyst for action? I think not just that we support something, but that this board's mission and charge in part is to set strategic public health policy. So if you could address those 2 points, that would be great.
Absolutely. I will start with the latter, which doesn't work in my favor. You may have to remind me of the former question, but
Okay,
I'm this year I am honored to be co-lead author for the Lancet Countdown on Climate and Health US brief. And it was just released last week. I'm happy to share a link for you to share in the
great,
follow-up materials as well.
perfect.
And the policies that we recommend are around investing in green infrastructure, certainly decarbonizing our energy sector as well as our transportation sector, but also investing in green infrastructure in our communities. So increasing access to green spaces, parks, as well as trees that has a number of benefits on not just our mental health, not just our physical health, but also our mental health. So those types of policies are things that we're seeing take place in communities across the U.S. In that brief, we feature policies that are taking place across different regions here in the U.S. So I think that'll be also helpful to rally around. But so CDC has, and I do remember your first question. So CDC has a group of cities and states that they support, and they're climate ready cities and states initiatives, and many of them are called BRACE grantees, Building Resilience Against Climate Impacts. There are a number of success stories on how communities across the US are building impacts, and I think that within that, those are some factors that we can look into. They're forecasting what the climate issues are in their community. They're also assessing what vulnerabilities may exist. If they're in floodplains, for example, if they have urban heat islands, they're forecasting that so that we can identify solutions specific to communities. That's the challenge of climate change is, well, this is a global phenomenon. This is happening globally. We're experiencing it differently locally. So here we may be experiencing issues with air quality. We may be experiencing issues with extreme heat, and occasionally we're also experiencing issues with flooding. But in the West, it's wildfires, and in the South, is continuing warmer temperatures, for example. And so we're experiencing it differently. And so we need solutions that are tailored specifically to our community. So I've actually received pushback when I've shared about our tree planting study, only once, but I have received pushback from someone that was in an area of drought in the West. And they said, yeah, trees sound great. That doesn't work here. So we do think that Green Heart is a green print for many areas to follow, but it's important that we also investigate what our susceptibility is, as well as how well these factors will work for our communities. So I point us towards the BRACE solution, where we're able to examine and forecast what's happening in our community so that we can have interventions that are specifically tailored for the health impacts that we're experiencing here.
If there's a link to the CDC
Yes,
reference,
I'll make a note
could
of
you
that
include
too.
that as well so that we
Yes.
can take a look at that?
Certainly.
To my colleagues on the board, questions? Advisory board members?
Well, I'll certainly raise the flag of the public health school over here. How you doing, Natasha? Good to see you. We're all very fortunate to have you back in town after your stint on the East Coast for a while. Welcome back. Look forward to following what you're doing, and this is just great stuff. I hope it makes its way into our curriculum as well as our policies locally. So thank you for sharing with us.
And thank you,
Absolutely.
Dean
Thank you.
Blakely. One of the, let's see, did I hear or see any other questions here? And know that you will receive, as I mentioned, a copy of this deck, which is highly informative. Certainly we'll be back in touch, and I'll be talking, and I see Dr. Howard, with the department in terms of how the department might be helpful here, here too. So, yes, Ms. Handmaker.
after new members of the Metro Council are in place in January, it would be interesting for Natasha to present this to the Metro Council. I'm not sure what the format would be for that and how you get that done, but
That's a great idea.
I just urge that we try to make that happen.
That great suggestion. And actually, what I was going to do, if Dr. DeJarnett is agreeable, is to forward it to both of the candidates for their reading. And perhaps that will, at least from a government standpoint or from the city administration standpoint, and perhaps those of us in our own spheres who have contact with council members, good suggestion, Ms. Anmaker, could also share, and we'll work on doing just that with whoever assumes the key to the city. All right, thank you very much.
Thank you very much.
Okay, now we will go back to Rebecca Hollenbach and Megan Metcalf from Councilwoman Armstrong's office before I rudely interrupted, and let them give us some background and answer any questions with regard to the creation of a lead-free safe rental registry that does enhance the code is currently on record. So Rebecca and Ms. Metcalf, floor is yours.
Good morning. My name is Rebecca Hollenbach. I'm our Policy and Equity Transformation Lead for the Center for Health Equity in the Department of Public Health and Wellness. And we've been lucky to collaborate with Councilwoman Armstrong's office for over 6 months on this ordinance. So I'll just talk a little bit about why this matters, and I'll let Megan chat specifics of the ordinance if you all want to know more after reading the draft. But basically, proactive lead inspections are a national best practice, and they're evidence-based. We have 2 cities where evaluations have been done, and instances of childhood lead poisoning dropped at more than double the rate of the states they were in. So we know that doing this helps reduce exposure to lead. The main goal of a proactive lead inspection ordinance is to go where we know that lead is and find it and either remediate it or remove it or abate it before children are exposed to it. And so by proactively requiring that of pre-1978 rental housing, you can reduce the environmental exposure that kids are getting from the soil in their backyards and inside their homes. The reason why we want to do this proactively, we've had some people ask, is because lead poisoning is irreversible. It's a neurotoxin that damages every system in your body. It has massive impacts on developing brains. That's why we're so focused on childhood lead poisoning, but it also affects people who will eventually want to become pregnant or who are pregnant. And it has massive health and social repercussions. One study estimated that the social cost of each lead poisoned child was about $50,000 to a society and community. And we've had almost 10,000 elevated blood lead level cases in our community over the past 15 years, and that's likely an undercount. So the goal of this ordinance overall is to shift from a reactive approach where we're only finding and testing kids after they've already been poisoned, at which point the effects are irreversible and there's permanent damage, and shifting to a more proactive approach which aligns with what we talk about in our health equity report and our Center for Health Equity, right? Addressing the root causes of health. What is housing quality? How can we find lead in our environment and remove it? So that's the purpose, that's the evidence base, that's the why. Megan can talk to you about the specifics of the ordinance and the advocacy efforts that she's working on. But thank you all for your consideration this morning.
Good morning. Can you hear me?
Yes.
Okay, great. Hi, I'm Megan Metcalf. I'm the legislative assistant for Councilmember Cassie Chambers Armstrong in District 8. I want to thank you all for having us and for holding this discussion on our lead safe rental registry ordinance. We think that it's a really targeted approach to addressing a problem that has gone on too long in our city. We have been working very diligently, and I'd like to thank Rebecca and Nick, Karen Handmaker, Abby Bowman Rogers, and the rest of the public health team who have been working extremely hard on getting the technical details of this right. We've also convened a very large work group to try to include all aspects that may be impacted by this ordinance. So we've got neighborhood representatives, housing and real estate representatives, education, children's advocates. We have tried to make sure that this ordinance is very specifically targeted to the types of housing where people are at the most risk. So we've carved out some fairly broad exemptions for obviously any housing that was built after 1978 when lead paint was removed from the market, but also any property that can show that they have done substantial renovations that have removed the lead risk would be exempt from this, as well as any multi-family units that can show that they have staff that has the expertise to assess lead risk and address them on property. We think that it really is the best way for us to ensure that no further children are exposed to this harm. And we are looking forward to it being introduced into committee today and hopefully for passage next week. And we would welcome any questions you have, but we do hope that the Board of Health will support this measure and endorse it.
Thank
and I
you
will
so
open the floor for
much.
questions.
Thank you so much, and thank the councilwoman. She is my rep, actually. So, good work. Questions from the board? Okay. Boy, we have quietness today. In your packet, we included a copy of the ordinance. We included a position statement that I bring before you for your consideration and approval. So that would have been in the materials that you received. And so given the interplay among many of the people on this phone with the councilwoman on the technical details of it, my hope is that we'll be able to lend our support. So the chair would entertain a motion of support for the lead safe rental housing position statement.
I'll move that. It's a really critical one.
Thank you. Is there a second? Thank you, Dr. Compton. Is there a further discussion? All those in favor, please say aye. Or raise your hand or whatever you want to do. Opposed? Abstentions? Motion carries, and we will disseminate this to to you guys, and it will go on record and be a part of
Thank
our
you.
advocacy strategy. So please thank the councilwoman again from the Board of Health, and we send positive passage energy to this effort.
Thank you very much. Have a good
You
morning.
got it. Uh-huh. So, let's see, Taylor, can you ensure that this gets transferred to Board of Health stationery, et cetera, and will disseminate to appropriate people and to the
I'll work
press
with Arlene on that.
and to the press. Ann Hawkins, a note to you guys. Okay, let me catch up on my notes. Second, Dr. Irwin, I saw you on the screen, has some brief good news and an update from Family Health Centers.
Right. Since Family Health Centers works on behalf of the Board of Health, I thought it'd be a good idea to tell you what we're up to each month, and I've just got a short summary. We are continuing to work on the transfer of the Portland property from the Board of Health to Family Health Centers. We're working with the county attorney to get that done, so that's underway. Also, our third and fourth most diagnosed conditions at Family Health Center is anxiety and depression. So last April, we decided to undertake a transition of our health center located on West Market, 2500 West Market, into a behavioral health center. So we have done that. And at this time, we have 2 LCSWs, 2 psychiatric nurse practitioners, a lab/medical assistant, and a pharmacist working at that location. And I'm telling you this today because we're going to release a press information to the press today. So I think that's a positive thing. That is located on the borderline of the Shawnee and the Portland neighborhood. So I think it's a good location to help serve the West End's needs for behavioral health and mental health services. And finally, Family Health Centers has 4 site-based pharmacies in its health centers. And this is important to us because that's one way we can generate some income to help serve our patients. We're in the process of establishing a 5th pharmacy, and that will be next to our Iroquois location on Taylor Boulevard. So I think it'll be a good service to our patients and will be helpful financially to Family Health Centers. And that concludes my report.
So you also have a mobile van. That's the one I was
Okay.
particularly
Yes,
interested in.
we've not received that yet. We have a mobile medical unit that we ordered actually 2 years ago through a federal grant. And we hope to receive that late in the fall or early winter. And finally, it's under production, and we've gotten some photographs. And that will be used to serve homeless persons residing in camps and on the streets. So we're looking forward to getting that and putting it into action.
Thank you. A lot on the agenda. So we'll track that each month. It'll be interesting to see what traffic is, so to speak, to your 25th and Market site and track the progress of that. So if you could update the points that you've given this month, next month, I think it will be informative to the board and a good piece on all of these updates. The chair's hope is that you get this out to your networks. That's pretty critical to get the word out. Are there questions for Dr. Irwin? Okay. Third on the update is a follow-up to board action taken at our last meeting where we granted an exception with stipulations to the public sewer system connection requirements for property owners for Mr. John Fuchs. You'll recall he appeared in person to talk about his case. Connie Mendel sent a letter to Mr. Fuchs defining his responsibilities related to this exemption, to which Mr. Fuchs agreed. We will attach Ms. Mendel's letter and materials to these minutes for the board's files. Any questions? And lastly, and I don't see her on, but let's, Dr. Eva Stone, are you on? She was stuck in traffic. So the piece, and I'll call her back at the next meeting for this. I hope you read, probably with horror as I did, and those of you who are within the academic system may not, and I have, and are working with JCPS or have children in the system, saw the 5-part series in the Courier Journal on why JCPS students can't read. And a link was provided through my update for that. It clearly was alarming and cries out for a system changing call to action. It clearly, the inability to read just exacerbates the health of children and then adults, as this stays with a person through life and creates incredible health inequities and disparities. And what I've asked Dr. Stone to share with the board is the actions that JCPS intends to take. Clearly, there is a connection among JCTA and the board and the system itself. But as a graduate of the system, it was really alarming to me and elicited from me personally, what is it that I can do? So I just we'll come back to Dr. Stone.
I'm
Any
on.
comments? Eva,
Yes.
there you are. Did you hear my part?
I did not. I literally
Okay.
just got on when you said we'll come back to her.
Okay, so let me just very briefly say that I was both alarmed with the articles that you and I had chatted. It was clearly actions require a commitment among JCTA, the board, and the system. But I'd really like for you to just very, very briefly talk about what the system from your vantage point may be thinking about / doing.
Well, I'll tell a couple of things. One is you all have seen the major work that has gone on with Dr. Polio and the board as far as changing some structural things in JCPS. I mean, as disheartening as all of this is, it is a systemic problem that is very complicated and needs change. So the biggest thing I want to share is the change in school assignment and the opportunities that will afford for students. So actually this week, yesterday, the applications were open for schools that are in what's called the choice zone, which is in some of the more at-risk areas in the city will have more opportunities for where they want to attend school. So that application process was opened yesterday. There's been a lot of work too, as far as outreach to families to give them support to apply for schools. And so, for example, there'll be an event coming up at Newcomer Academy. It's November the 14th, I believe, but from 5 to 7, we'll be there helping families with translators. They'll have sessions to answer questions specifically about school assignment and where they can go to school. And so that's happening. That's just one event that I'm involved with, but there's a lot of those things happening around the district. So the school assignment plan, very big deal. And then from an academic perspective, there's a lot of internal work about addressing these issues. I think everybody probably saw the article about the very large grant that funds the district has received to help support more of our at-risk schools. And so Dr. Polio has been very committed to increase resources to our needier schools. And then foundationally, from a health perspective, we are working very hard on making sure every child has access to healthcare. You all have heard me say this again and again, but 1 in 5 kids in JCPS is not current on their vaccinations. We have just around 10% of our 6th graders have had that required physical exam they're supposed to have for 6th grade, and it's about 50% of our kindergarten students. And what that suggests to me is children aren't regularly accessing the healthcare system. And so what we've been doing isn't working. So we've got to start thinking differently. So foundationally, from a health perspective, if a child is unwell or has a poorly managed chronic illness. We know our kids with chronic illnesses miss school more often than our kids without chronic illnesses. We're working with nurses to better support those students. And then we're doing some major things around some foundational stuff. Vision screenings, failed vision screenings. We don't have places to send children in Louisville who fail vision screenings. We give vouchers to children with no insurance. There's a lot of children that have no health insurance. And there's one location we found in Louisville that will take those vouchers. And so we've been reaching out to some partners to try and get some things in place to help kids have access to vision care, follow up for failed hearing screenings, and then of course just access to healthcare in general. We continue to work on getting school health services in the schools, and we've worked very hard with community partners to do that, but we're not making great progress on expanding that far and wide. So we're getting ready to issue an RFP, I hope, coming up shortly, to bring school health services, to expand who we're offering the opportunity to open clinics in our schools, with an emphasis on our schools that are not doing well academically and our schools that are in what's called the choice zone. So that's a big bird's eye view, but there's lots of work happening behind the scenes to make things better for children and families and get them reading so that we're addressing those social determinants of health to help them succeed in school.
Thank you. Are there questions for Dr. Stone or comments? We have a quiet group this morning. And Dr. Stone, I'll follow back up with you on all of the initiatives and provide an update to the board. Dr. Eccles, did you have something? Okay. Thank you. Dr. Howard, you're up for a brief recap on key priorities prior to the end of the year and anything else.
Well, good morning. Thanks to the board chair for the opportunity to present to you all again, and I will keep it very brief as I know we're moving to less than 5 minutes. I do want to take a point of privilege to say, as the spouse of an educator and a district level educator, at least although in a different district, those articles really resonated with our home. And I've maintained today, even though I am a physician and work in the public health sector proper, that the number one opportunities for improvement of health and well-being, not just here in the Louisville Metro, but across the world, is economic prosperity, probably number one, and number two is education. And those things got to be fixed before we can fix any of the underlying health issues, because we are patching the dam, so to speak, on health issues until those issues are solved at a broader scale. So we certainly want to help however we can to support our school system in accomplishing those goals moving forward. I want to spend most of my time today talking about one major issue that has been a chronic issue at the Department for Public Health, but it seems to be acutely worsening over the last quarter, and that is recruitment and retention. In your board, in my letter to the board, I hope that each of you noted that we have 98 vacancies across the department. That is up from approximately 75 vacancies, which we typically range between 60 to 75. That level of vacancies includes 20 critical nursing positions, and the impact of these vacancies are real across the department and are resulting in decreased level of service offerings to our community. These issues are not just related to pure inability to hire, people leaving. In fact, we're turning over quite high. As you may have saw, since May of 2020, we've hired 70 new people or had 70 new onboarding events. 38 of those were new hires, 22 were new contractors, and 10 included staff promotions or transfers within the department. We are just simply not able to keep up, even with new hiring, with the amount of immigration away from the department. And there's multitude of reasons for these, and I don't need to expound upon them to explain the issues that we are facing and that are real across all of Louisville Metro government in terms of hiring and retaining talent. I will tell you that we've had 6 recent job offers that we have conveyed over the last approximately 2 weeks, and that were not accepted. And the most common reason cited to us was the rate of pay comparative to other healthcare competitors in the community. As of, I've been asking for specific data from our departments as I'm conducting executive level meetings across the department. And I continue to be told that these impacts are real. And some of the specific data that I've gotten is that our specialty clinic, which includes TB, STDs, et cetera, is turning away approximately 16 patients per month that could potentially be treated. And we're hoping they're getting care in the community, but we're having to turn that many patients away per month due to pure staffing inefficiency or staffing vacancies. Our TB clinic currently can only accommodate 6 to 8 patients per day. And we're scheduling at that rate, we're scheduling out at 4 to 6 weeks, which is really unacceptable for addressing tuberculosis potential outbreaks in our community. We would like to see those patients same week or the following week. Taking a point of privilege here, I will tell you that there has been a TB event in our community that may result in a fairly large outbreak. And if that happens, we're going to be in a very difficult position in terms of addressing that because of our severe staffing vacancies. As we saw with COVID, the ability for public health institutions to be agile, to be able to mobilize staff quickly, and to have what may seem from an outside of some reserve staff for response is absolutely critical, and we do not have that currently in the Louisville Metro Health Department. I will also note that due to pay issues, specifically with folks being recruited away to other high-paying areas in the health sector in our community, we have turned over our health service supervisors since 2018 at least 3 times, probably more like 4 or 5. That results in significant losses of institutional knowledge and severely hampers our workplace culture and morale. I don't think I need to belabor that point anymore. The bottom line is we have severe staffing shortages. If we have another COVID outbreak or heaven forbid, a different version of an infectious disease outbreak, we will be severely limited in our ability to respond due to these vacancies. We are working up the chain in Louisville Metro government to address those. And I want to acknowledge that those issues are not just unique to us in Louisville Metro government, but across Louisville Metro government.
So this is an issue that probably needs to be handled. And I know that you've had discussions with mayoral candidates as well going forward in terms of putting a priority on public health. And the nursing shortage, as you indicated, permeates the entire system. But it also calls for prioritizing what activities the department actually does and emphasizes the need for partnerships with other organizations in the public sector, in the social service area, and in the non-taxpaying sector to step forward and provide those services, because those are the people you're competing with anyway. But this should be a priority for up and coming. So it's a question of what's the top priority of a next gen public health department and providing access. And clearly it's access for people who don't have other access. The report that Dr. Irwin put forward in terms of the comprehensive expansion of the services that Family Health Centers offers clearly is one area that, while it doesn't specifically address TB, it is out there, and there are other groups in vulnerable areas who perhaps could step forward. So we'll continue to work on this and press the importance of the priority of public health in the incoming administration. So thank you, Dr. Howard, and thank all members of the health department team for everything that you do that is many times unheralded. Other updates, I didn't see Dr. Val nor Ms. Manson for K&A update, but I did see Shelby Somerville from GLI.
Thanks, Heidi. I don't have a long update today. I believe last month you let everyone know that we're working on our state and local legislative agendas. our local legislative agenda, which does have some of the topics that we cover in this group, is going to be released in January at our first Capital Connection event of the year. We're hoping to have the new mayor speak at that event and release our local legislative agenda at the same time. So I encourage you all to attend that. We don't have a date yet, but we should in the next month or so after the election. So I'll be sure to update that and send out the legislative agenda once it's finished. And that's all I have. Thank you.
Thank you. Perfect. Under committee reports, Dr. Batista Cervera had a mandatory training program this morning and has proceeded with meetings of the committee. Dr. Eccles is on. Anything you wish to add, Dr. Eccles?
No, just that our next immunization advocacy committee meeting will be next Thursday afternoon from 2 to 3. If there's anyone that would ever like to join to just provide us any additional insight or perspectives, we are always happy to have more voices and more participants.
Thank you. And the previous meeting was incredibly a great discussion on the part of all those, lots of community members, and great job. Thank you. Is there any new business, comments by board members or advisory board members? I guess at this point in the meeting, silence is golden. Please, as someone who is a healthcare person, please be careful during the holidays. And there's lots of, not being a clinical person, there's lots of stuff flying around. Just take good care of yourself through your networks. Make sure people are boosted, and that especially for children, the outbreak of RSV seems to be literally catching on. And so let's just watch, read, and make any recommendations you need. Any announcements from the board? All right, our next meeting will be December the 7th. Interesting that it's Pearl Harbor Day, I believe. It will be virtual, if there for the grace of the tech gods. Is there a motion to adjourn if there's no further business? Thank you, Dr. Grisanti. Is there a second? In favor, aye. Opposed? The meeting is adjourned. Happy Thanksgiving and see you in December. Take care.